Okay, I think we shall begin our webinar session. Good afternoon and welcome to our weekly webinar organized by College of Physicians Malaysia. And the theme of the month is palliative medicine. And we are very fortunate today to have with us our chairperson for today, Dr. Ummi Affah. She's a consultant in palliative care from Pantai Hospital, Kuala Lumpur. Without further ado, let us welcome Dr. Ummi.
Hi, Assalamualaikum, and a very good afternoon to IB to all of you. I am very honored to present you our speaker today, which is Dr. Teoh. He is one of his kind, okay? He is family medicine specialist, graduated from University Malaya back in 2006, and then pursuing his specialty in family medicine in 2015. Before that, he did obtain an Executive Master of Business Administration from Wawasan Open University back in 2010. After specializing, he then pursued the palliative care medicine as subspecialty, palliative medicine in primary care through subspecialty program awarded by Ministry of Health in 2022. So he is very active in writing, obviously, and also, producing numerous publications, presentations, and active involvement in guideline development. Okay, he is currently serving as the head of Klinik at Klinik Kesihatan Salak, Sepang, and he's currently piloting the children palliative care in the community. So let's hear from him, Dr. Teoh.
Yeah, thank you, Dr. Ummi. Actually, I am just as family medicine physician, we have no special interest on anything, so we do everything. That's why I end up doing everything. So I have special. I mean, I do everything, but I prefer to do something that can actually help myself in future, which is doing palliative care in community, right? So what will be the difference between palliative care in community and also in hospital? Because I don't want to die in hospital, so I prefer to die at home. That's why I have to set up the system to prepare for my day at home. Yeah, that's why come for this home domiciliary palliative service, right? So let me share my slide. Okay, so yeah, I guess you see my slide, right? So I'm trying to utilize our domiciliary service in Klinik Kesihatan to actually expand the thing a bit more for palliative care, so that in future when I die one day, I have a good team to support me at home, right? So so today I'm not going to tell you all anything new. It is just sharing my experience doing domiciliary or people say home palliative service in the perspective of Klinik Kesihatan, right? So you see, this is my team. I have a small room. My pasukan domiciliary actually, so we have small room in my clinics lah. This is during the Hari Raya, right? So, okay. Okay, right. Just to as an introduction, domiciliary care service actually is already there in our Klinik Kesihatan service, right? So for quite some time, right? So actually we call it Perkhidmatan Perawatan Domiciliary (PPD), right? Mainly actually is to provide continuous healthcare. Actually, this is not the mainly. This is actually one of the objectives to provide continuous healthcare. The main function of this domiciliary team is to empower the family member and educate the family member and the patient itself to actually having self-care, so that they no need to be rely on hospital so much or rely on any medical personnel so much, so they can do their thing at home, right? This is the initial objective of it. So actually, this is using the concept of a home care service originated actually in 2010, it is already there in the hospital. So what they do in hospital is that they have a home care team that go to the home to provide care for patients who have stroke. So with that as concept, so in KKM primary care premise, they initiated a program, a holistic care for elderly, disabled, and single mother that time, right? So yeah, so it's actually run in our all the health district in Klinik through Klinik Kesihatan. Right. So what is domiciliary care service? Is a holistic service provide to stable bedridden patient who has been discharged early from the government hospital and require continuous care. So the service actually delivered in patient home, not in the clinic, by this multidisciplinary team from a selected nearby clinic. Okay, so roughly is that we provide care for people who are bedridden, who bedridden. Also, there is definition there. They cannot manage themselves and need help from caretaker. And one important thing is that to be accepted into the program, they must have a caregiver who is able to take care of the patient. We do have experience of receiving case saying that they have caregiver, but the caregiver is an old mother, right? So this is actually an adult 50 plus, old mother already for 70, near 80. So actually the patient cannot even take care of the patient. So so with that we have a little bit of problem, because the whole principle, the whole purpose of this service is to actually empower the patient to learn self-care, right? So this is roughly the definition of the thing. Slowly you will see the evolution of the program. Okay, right? So service actually run by health clinics. However, because we don't have so much of manpower, that's why some certain area actually run by PKD, under PKD. For example, like my district, Sepang district, we have 4 Klinik Kesihatan, and Klinik Kesihatan Salak is the one who cover the whole district. So depends on location lah. All right. So only cover my own territory. We cannot go above that, more than our territory because of medical legal issue, right? So the case, we are actually a bit passive. The case actually refer by hospital normally, but now actually with this awareness on home care, Klinik Kesihatan itself also referring the patient for this service. All right. So right. So it is actually not that the whole of the Klinik Kesihatan going to take over the care, but actually it's a collaboration between the hospital and the healthcare and the health clinic, right? So for I know that probably the audience, actually you are physician, a medical physician, a medical officer, work in hospital, right? So if you have a case that who is bedridden and you think patient needs home domiciliary service, no matter this is actually palliative or what, you can refer the case through your hospital PPD coordinator. You don't need to go and call the clinic and ask, hey, Klinik Ampang, do you have this or not, this service or not? No need. You just refer the case to your PPD coordinator. Or the hospital has a PPD coordinator. They are going to filter the case and send the referral to the respective district. Right. So yeah, so we work office hour. Normally within 3 days we are going to do visit already lah. All right. So okay, one more important thing here I want to stress is that I know a lot of you maybe have experience sending the case to us where the referral letter will be very, very, very simple, no detail there. So please provide us with a comprehensive care plan, very detailed kind of thing, because when we go to patient home, we have no access at all to patient medical records. we don't know what patient what are their diagnosis, what treatment that they get. So please provide us with a care plan or at least a good referral letter. Right. So what service provided actually from this domiciliary care, right? So domiciliary home care. So we provide mainly three service. One, medical care. Medical care, I mean, include all your medical management, which is your pressure sore, how to do wound dressing, change tube, right? Catheter, right? So check your blood pressure, all those things. But this is only for bedridden patient. We can't, for the time being, we can't open up for everybody because we have resource problem. So for the time being, it is for bedridden and a bit of palliative care patient. Right. Second is rehabilitation activity. They are actually stroke patients who are bedridden. All right. The first 3 months after the stroke, the recovery of that patient is you get the peak at the 3 months time. So we want the rehabilitation activity to be there at home also. So we do this rehabilitative domiciliary service also. And finally, palliative care. Palliative care, for the time, most of the time, what I get is terminal care support. So we go and help the patient to for their terminal care symptom relief. Right. So, okay, who actually eligible for this domiciliary service in KKM setting? They must be Malaysian. All right. So foreigner, unfortunately, we weren't able to support. So case refer from from government hospital. They have a clear home address. They have appropriate caregiver. All right. So because sometimes we have difficulty to discharge the patient, right? So the patient don't have a good carer, they don't have a good caregiver. So end up everything they rely on our medical staff to do it. Then it defeat the whole purpose of it. All right. So, but another thing is that the patient must be agreeable for that lah. So we do have we do have referral that we go to the patient home, and then they chase us away. Yeah, so they say, yeah, why you come to my home? Yeah, all this thing. So they don't really agree with it, but they said, yeah, the doctor said, yeah, somebody going to go to your home lah. Then you can reject them when they are on your doorstep. So yeah, so must give we must get a proper written permission. All right. So okay, right. So this is now dive into our topics. Okay, our title, the domiciliary palliative service. Right. So we talk about bedridden in the beginning, but this palliative service not only applicable for bedridden patient, but it is bedridden like when they are ECOX 3 and 4, right? But they are not that kind of bedridden that they can't move at all, right? ECOX 3, right? So ECOX 3 can be referred. So patient with advanced cancer, yes, they can be referred into the palliative service, right? So although they don't have a histological diagnosis, but radiological or clinical diagnosis will be adequate. But we really need a very detailed kind of summary on the diagnosis that they get lah. All right. So criteria for patient non-cancerous, we are starting to accept non-cancerous patient, especially COPD and chronic heart failure patient. End-stage renal failure, not that much yet. Okay, neurodegenerative, actually nobody refer us so far, but we are trying to expand the service a little bit more to non-cancerous. Why we want to expand this to non-cancerous? Because this group of people, this group of palliative patient with palliative needs has no, hospices in all the town is not covering non-cancer condition, right? So if it is cancer, hospice will cover, but non-cancer, yeah, so nobody cover. So we try to complement each other. Since hospice already doing a good work on cancer, so the domiciliary actually try to do the non-cancer. And it is more actually appropriate for this non-cancerous condition to be handled by primary care because they are actually our bread and butter. For example, we do have patients get referred for palliative service, very poorly controlled diabetes with bilateral below knee amputation done. So they are, yes, they can move around, but they are actually, the movement is limited, right? So diabetic retinopathy. So this kind of case we are actually supporting. Also, another example, non-cancerous condition is HIV virology failure, right? So they first line, second line, not helpful. Patient cannot afford to buy the medicine, so they deteriorate. Then we are supporting them, right? So this is one extra thing that non-cancerous condition that accept by domiciliary palliative service, right? Okay, so the referral process almost the same. This only highlight that for private hospital to refer the case, so they can't refer straight away to the domiciliary. They have to refer the case to the government hospital or Klinik Kesihatan to be assessed. The reason being because domiciliary by itself actually is run by paramedics. When they have problem, they will get their medical officer or specialist to come into rescues, right? So means that we need a primary team to actually handle the patient if it is any problem. So let's say this patient belongs to one hospital. So if we have problem, we can always refer back the patient to that hospital or refer back the patient to the respective Klinik Kesihatan, right? So yeah, we need that. They can't be straight away refer to the domiciliary, right? So normally we say non-cancerous diagnosis must go through palliative care physician, a specialist. This is a little bit old kind of what we call policy. Now actually they are empowering the other specialty to actually allow to refer those palliative cases, right? In the beginning, we the policy to be set as such because we worried there are people just refer patient for BP check, sugar check. So for those not really palliative cases lah, so they must be certified by palliative care physician. But since now the awareness of palliative care also increased, so more people know about palliative care. So they can refer also if they don't have palliative care physician. Right, so yep, this is almost the same. We will actually provide the service in 3 working days. All right, so home visit, we will actually visit within 3 working days if possible, right? So if actually we don't need to visit, then we will do phone call at least 2 weekly lah. I mean, this is not for terminal care. Terminal care normally we will actually visit 2 times a week as needed, right? So this one, okay, right. For domiciliary, we have discharge criteria for domiciliary care. Normal domiciliary care for rehabilitation. Normally we try to discharge at 3 months. 3 months of 3 months lah. So if this is palliative, we going to keep them for 6 months lah. Let's say patient palliative so talk about terminal lah. So let's say they require care after 6 months. Actually we can discuss again and re-refer the case again into the program. So consider no limitation actually, right? So for certain case after patient pass away, the domiciliary team will go and do bereavement visit. But most of the time, we won't just walk in like that. We will call them, see whether they need us or not. In Malaysia, normally bereavement is not so welcome by family member. So they will say no need. So they are okay with it. So not many bereavement visit that we have done. Right. So now, so that is just introduction telling that what the domiciliary service is lah. Compared to hospice, right? Hospice normally they are NGOs. they get donation, they get their fund by themselves, they go to visit their patient for what they call they go and visit the patient on their own, right? For most of the time is cancerous patient, right? So for this domiciliary service, most of the time we do rehabilitative, palliative, and also medical care, and it is funded by government, so it is actually free kind of service. All right, so next, yeah, so probably this is more practical for you all, is that how you want to see your patient at home, right? What is the approach at home? In clinic, we know normally we will do history examination, investigation, all those things. But at home, it is patient territory. So what should you do, right? I may not say what should you do, this is just what we have done at patient home, right? So, yeah, my mouse. Okay. All right. So, yeah, so want to introduce you with this PC home framework, right? So, I'm not sure about if you work in primary care. Yeah. So, when we talk about how you want to assess an adolescent, people talk about HEADS frameworks, HEADSSSS. So everybody will know about that lah. So for home palliative care at home, so we try to utilize this PC home frameworks. Actually, it is just a mnemonics kind of thing. So it's a structured approach, how you approach for primary care setting, right? Primary care setting means that in your primary care clinic or at patient home, right? So the component of it is that first, physical needs. You need to assess what physical needs the patient require. Second is you assess their care environment. Third, their healthcare you have to coordinate their healthcare. So look at their emotional and outlook well-being. Number 5, look at the meanings and spirituality. Palliative care talk quite a lot about meanings of life and spirituality support, right? So finally will be end of life planning. Right. So, yeah, for people who are just now, I just asked who are the audience. Say some of them are in primary care. So if you're in primary care, probably you know this is Scott and Davis model of consultation, right? So you got A, B, C, D there. This is actually we utilize this model to help us to assess the physical needs. Yeah, what patient actually needs, right? So A stands for acute. What patient needs acutely? Yeah, will be patient management, right? So pain management. So what is your pain score? How bad the pain actually affecting you, right? So yeah, so whether the patient needs what kind of morphine the patient needs, what kind of painkiller patient needs, right? So other than pain will be a symptom control, whether you're short of breath or not, right? So lethargy, vomiting, constipation. Ask about all those symptoms according to their condition, right? So pain management, symptom control, and acute complication, look for complication. For example, if they have breast CA, right? So at home, so yeah, the acute complication, it can be bleeding, right? So from the site, from the wound, right? So have to ask for all those complication thingy. For example, like we talk about non-cancerous condition, diabetes poorly controlled, yeah, hyper. Yeah, so it can be that acute complication. Because you ask that, then only you know how you're going to manage them. All right, so A settle. Normally after A, right, we won't go to B first, we go to C. We talk about the chronic condition. What is your chronic symptom management? So let's say the hypertension, diabetes, you want to control hypertension, they control diabetes. Yeah. What are their functional status? What can they do actually? So can they walk or not? Can they go to toilet or not? So this is actually assessing their needs lah. So if you cannot walk, what actually patient require to help them mobilize around? Wheelchair, or you cannot go to the wheelchair. Probably you want to have a small bed at the side that you can move around, not the wheelchair, the declining wheelchair, right? So if you can walk, yeah, so walking frame, or you need a walking stick only, that kind of functional status, whether patient can take bath themselves or not, right? So need to assess their function, review their medication, right? Chronic disease core management. If they are HIV, so make sure they are, I mean, they are non-cancerous condition, HIV virology failure. Make sure they may still on their hearts, although it is already resistant, but at least it slow down the progress a bit, right? So all the chronic disease core management. Then after A, C, then we go to D. Actually, we call disease prevention, right? So we want to prevent further problem. So look at the nutrition status, right? Preventive measurement, right? So preventive measurement is that mainly prevent them to get more harm lah. Fall prevention, fall from bed, right? So if their eyesight is bad, then make sure you don't have a carpet at home, right? So yeah, next, whether they can exercise or not, what kind of exercise they can do, right? So stretching exercise, if they are on bed only, how you want to do stretching? You don't have a running treadmill or whatever, right? So you don't have a helper to do the stretching. So how you want to use the towel to actually stretch your leg to actually reduce all those contracture, right? So anticipatory complication. It's the same like acute. You need to anticipate what will be the problem. For example, patient with colon cancer, you may have this again a bleeding, or you may have this intestinal obstruction, right? So yeah, so if you have that, what should you do? What will be the action plan to reduce it? Or you want to take whatever laxative first or whatever. So yeah, so you need to anticipate what may be the problem. Finally, you go to behavior back. Behavior actually is empowerment and educate them about symptom reporting. Don't report the problem late. If they have complication or whatever, they have bleeding, okay, they have to seek help early rather than it is already massive bleeding, then only you want to seek help, right? So this is the assessment that we do for their physical needs, right? So second is care environment. So this one people will say we are really jaga kain, tepi kain orang lah. So we go to the patient home. Other than seeing the patient, we are actually seeing their home also, their care environment, right? Comfort and adaptation. Bed, right? So what kind of bed they have? Is this patient need a hospital bed or not? Yeah, so for example, I have one patient actually, quite poor patient, people help her. So people help her to get a hospital bed. Yeah, so the hospital bed, find that when we go do visit, we see the hospital bed actually live in the living room. Why? Because the hospital bed cannot go into patient rooms because his room is so small, right? His room is so small, and this lady actually quite obese lady. She want to sleep with her daughter, her young daughter. So they need a queen size bed lah. They put the bed on the floor because obese man, you cannot climb up the thing. So the bed is on the floor. So people kasihan, get a hospital bed, but end up the hospital bed is not being used, right? Put as a decoration over the living room, right? So you have to assess their comfort and adaptation. Toilet, okay, go to their toilet and see what kind of toilet they are using, right? Is it a squat toilet? Is it a sitting toilet, right? I do visit patient in Pulau Ketam. They don't have both. Their toilet is neither a sit toilet or squat toilet. It is just one hole, then drop into the sea. So that kind of thing, you need to adapt. Like, oh yeah, if that is the case, how you want to do adaptation on their toilet thing, right? So yeah, normally I would say normally when I go to do home visit, right? So I will have one habit that I will pinjam their toilet. So I will walk to tell them, can I pinjam your toilet lah? So yeah, I go to their toilet and visit their toilet, see the lighting, yeah, whether it is wet or not, sitting or whatever. Yeah, so on the way that I walk back from the toilet, I definitely, because Malaysian so our normally toilet we will pass through the kitchen. So you will be there in the kitchen. So at the kitchen, I will ask for permission. Can I see your fridge? So I open their fridge and see. Yeah, you see what kind of nutrition they have, what kind of food they have, right? So they may have a lot of nuggets or those things there. Yeah, or you see, or leftover food, right? So then roughly you know that, what kind of resource that they have, right? So they are Caucasic, so probably they need more meats or whatever, but you don't see meats there. You just see a lot of mee goreng, pizza, all those things, right? So a lot of leftover food inside. Yeah, so probably it gives you some idea actually how's their living condition and their support system, right? So we talk about resource, the financial and the nutritional, indirectly from the fridge lah. Then indirectly you know that so what is the financial status, right? Financial status, I have my staff give me a very interesting way to measure financial status is to see how many TV they have at home. Right, you go to the living room, you see one TV. Go to the bedroom, one TV. Go to the kitchen, one TV. Yeah, probably financially not so bad. So look at their sofa, whether they don't have it. Yeah, so the cleanliness of the home. Yeah, so if you see potentially they have financial problem, probably you want to offer them what kind of resource, JKM or zakat or whatever, to handle that. These are the things that patient won't tell you. You need to see from their home, right? So emergency preparedness, actually for care environment, the mnemonic is cares also lah. So emergency preparedness is that if it is emergency, what they are going to do. They have their neighbor, okay, or their family member. If their family member go to work, then how, right? So if you want to get your neighbor, have you tell your neighbor or not? If this is this kind of patient like terminal care, so if you think, oh yeah, if it is emergency, I want to send my patient to hospital, then whether the neighbor keen to do it or not, so you have to prepare it well. All right, support system and social interaction, whether they have friends or not. If let's say they have problem, who they going to get their support. This is another aspect, right? Okay, so a little bit more. Yeah. Right, health coordination, quite easy for a doctor. Primary and specialist care, we try to actually coordinate the care. So as primary care physician, we say, okay lah, so if this is something not too essential, not giving to give you a lot of impact, probably no need to go anymore since you are bedridden already, right? So we will provide most of the care at home. So you need to coordinate it, right? Some care that you unavoidable, you must go, then go lah. Then but make sure the appointment will be like easy for the patient to go, right? Polypharmacy, medication review, right? Make sure patient, because patient may go and see different department, they get different medicine, sometimes overlap, something polypharmacy, sometimes you have drug interaction, you have to look at that, right? Then the final coordination is look at the advanced care planning. Advanced care planning is another lecture by itself, so I'm not touching it much, right? It mainly is to see what will be your future plan lah, yeah. Okay, so then we go to the O, 3 more to go. O, outlook and emotional well-being. This is more not so medical already. Most of the doctor will say, yeah, this is not my job, but this is very important, right? So emotional and psychological well-being, right? So emotional health, whether they are sad, they are happy, so they cry always, right? So yeah, they are emotional, right? Then the mental health, whether they are go into the depression, they have psychosis or whatever, right? So what is their outlook and coping? How they cope when they have stress? Let's say now I have pain, I can't sleep. So what is your coping strategy? Right, so I just leave it lah, I cry lah, I make noise at home lah, I go and disturb my caretaker lah. So so this is how they cope. You need to understand that, and then you need to correct it, right? What are their total life quality? What can you do actually? Can you still enjoy what you previously done previously, your hobbies or whatever, right? So we have to assess this one to so some patient actually they just their life is getting, they are there, they are breathing, but they are like zombie lah, waiting for that time, right? So no life quality at all. Nobody visit them, right? Yeah, so whether they are in isolation and their social engagement, right? Very important. A human is not live alone, they live in a community. So if they are in isolation, they will feel very bad. So elderly patient, maybe their chuchu come over or not, their friend come and visit them or not, or very young patient, their friend come to visit them or not, play game together or not, right? So yeah, open communication. So and also navigating grief lah. This is actually these two actually mainly for the caretaker, right? Because most of the time we take care of the patient, we don't really talk to the caretaker. No lah, probably with the balik. We talk to the caretaker about the patient. We don't care about the caretaker feeling, right? So yeah, make sure anticipate whether patient the caretaker will have grief or not, right? So tell everything that the patient and caretaker want to know. Tell everything. So make sure they understand everything. Because some caretaker or some patient being polite to doctor, they never ask much question, right? So they just keep that thing into themselves, right? So try to handle that. So finally, not finally yet, so meanings and spirituality, actually, this is very, yeah, meanings already lah. So goals and value, actually, what is your goal? What is your value? What is the your meanings of your life? Okay, this make them reflect themselves lah, right? So see where, because without this reflection, with this reflection, actually, patient can actually plan their unfinished business, do something so that they don't leave something behind, right? So they can reflect, okay? They want to leave some legacy, all right? So one example of that reflection and legacy is that this is all together lah, the goal and reflection. One man actually quite, I mean, I got a lot of pain lah. So we pay, I mean, morphine, very high dose, so not so helpful. Then we talk a bit more about your goal and value, talk about legacy thingy. So actually, the meaning of life for this patient is his daughter. His daughter very young only. I mean, kindergarten or primary school or something like that, very young only. So yeah, so he said this, she is the meaning of my life lah. So I work so hard, I work day and night for my daughter, and now I'm going to die. I'm suffering. I'm so much of pain, right? So yeah. So with that, then we asked her like, what do you want actually? So she said actually I want to see my daughter. I want to see my daughter to get married. But this is only a primary school girl, how to get married, right? So we tell her, okay, we tell him that, okay, we make a legacy. So actually we do a video. So we do a video and we say, yeah, we are going to make this video. You are not going to be there in your daughter wedding ceremony, but you will be there. All right. So we made a video and we pass that CD to the mother, right? Saying that, yeah, this is some legacy left by the father. The father want to be there in his daughter wedding ceremony. So then the patient, actually being the father, feel quite touched about that lah, because he know that he will be there in his daughter wedding ceremony, although he is not there anymore, right? So with that, actually, if we consider this an unfinished business lah, so he finished that off. So the pain, actually, the total pain actually reduced a lot. So it helped us to reduce, to have a good rapport and reduce the morphine for this patient, right? So assessment of spirituality needs, this one takes quite a lot of time. You need to be there for 1 hour, 1.5 hours, right? Cultural and religious practice. Okay, understand what's their cultural needs, what's the religious practice. Because sometimes we will always say, this one very important because normally it is issue of feeding lah. So end of the life, we don't feed patient. Evidence-based say we don't feed patient, but culturally we actually take feeding as a way to show love, right? So we will give. So you need to understand that lah. some religion actually they say, oh yeah, if you're going to die, you cannot die in hunger. You must eat something. So we must understand that and we need to practice that, right? So okay, right. Finally, end of life planning lah. So what's their preference and goal of care? So what you want? Actually, I don't want to have pain. Yeah. So I don't want to have I don't want to have more suffering where in my end of life. I don't want resuscitation. I don't want oxygen. Right. So yeah. So unfinished business also you need to handle. Right. So then you have to see whether they have access to hospice and palliative care service or not. Since now they already with us, so okay, they have palliative care service support, but sometimes they want to go back to kampung, so kampung don't have. So how you want to handle that, right? Communication with family and caregiver, right? So then finally end of life arrangement and legacy. Some patient they want to plan their own funeral, right? So some of them actually do that. So yeah, you can actually arrange from that lah. So the mnemonics for this is peace lah. All right. So this is roughly what the things that I do lah. This roughly is just a guideline, it's a framework lah that guide me how I'm going to handle my patient, assess my patient at home or also in my primary care clinics. All right. So conclusion, we need to enhance the quality of life of the patient. We try to bridge the gap in palliative care within the primary care setting with this framework. All right. So this is some of the thing that we do at home. Yeah, my nurses actually, yeah, I can't see much. I cover the thing. Yeah, so they are doing some procedure on the patient, right? So down here is me with some of my my psychologists to see some children palliative cases at home. All right, my OT is doing some work, doing some passive exercise. Right, this is my clinics. Yeah, so this because people come and visit my clinic, that's why we run clinic together with them lah. So this is how my clinics look like. Yeah, so yeah, I'm piloting the pediatrics palliative clinics. So pediatric patients do come to my clinics. So I support pediatric palliative patient at home also. Right. Right. So with that, I thank you.
Thank you very much, Dr. Teoh. Very informative. So at this moment, I am opening the floor of audience to type your questions so that we can answer any doubts or any questions, burning questions from the audience.
Yeah, one thing I want to say to encourage the doctor to take up palliative care. Yeah, so people do ask me lah. I mean, even family member or friends or colleague ask me, hey, palliative care, you cannot earn money, one. You cannot earn much from palliative care. So, and all your patient dying. So, don't you feel this is bad? Yeah, so why you want to continue to do palliative care service lah? So then I normally tell my friend or tell my staff lah, say, yeah, no worry doing palliative care. Palliative care very easy because whatever you're going to do, patient going to pass away also, patient going to die also. But you do a little bit more for them to make them reduce their suffering a little bit more, then actually you already do your job. You already capai your KPI. So very easy. Compared to other internal medicine or whatever. So it's too bad. I know a lot of internal medicine here. So I need to treat the patient, make sure patient going back home healthily. So I think it's a little bit more difficult compared to palliative care. I just need to do something to reduce the suffering before patient pass away. I mean for terminal care lah. That's already good for patient, important for patient. Patient and not patient won't come and thanks me. Family member will come and thanks me at the end of it, right? So I encourage people to do that. Yeah.
I totally agree with that. It's not about the money.
Yeah.
About the satisfaction, isn't it?
Yeah.
Because I'm in private sector. So if the patient's referred, I'm happy. If the patient's not referred, sometimes I'm sad, not because I'm not earning, but because I know that the patient's going to suffer.
Yeah.
So with referral or not, the patient is going to die.
Yes.
You can make a difference at the end of the day. It's already reaching your KPI.
Yeah, correct.
And the things that you do now will multiply in 10 years to come. But you don't want them to visualize their loved ones dying and
Yeah.
suffering.
Yeah.
So we have a questions, Dr. Teoh, coming from our participant asking
Okay.
about your experience in palliating.
Yeah. So yeah, I saw this is talking about palliating pediatrics patient, right? So yeah, so actually not I mean it is really far more difficult compared to doing something for adults, right? So yes, the main challenge is to communicate with the parents, right? So communicate with the parents. What I normally practice is I tell the parents that talking about intention. So what's the intention of you doing such an action? Let's say giving morphine. Parents don't want to give morphine because they worried morphine cause side effect to the child. Right? So they don't want to take any intervention because they worry their child going to suffer. So I tell them how I communicate with them is that, yeah, let's look at the intention, why you want to do that. Sometimes we no pain, no gain. So you have to do something extra so that the child can be more comfortable in future, right? So yeah, the intention of giving morphine is not to make your life shorter, but make your child not in pain, right? So we need to talk to them like this lah. We cannot say, yeah, take morphine. Yeah, you don't take then the child will be the pain. No, I have to very slowly tell them. Yeah, I have to spend a bit of time to tell them. But mainly we have to show that, yeah, we really care the patient. It is not only giving something to them, right? Yeah. Also trying to actually children very easy. Not children very things say very easy. Children if they are not suffering, they start to smile already. When the parents see them smiling, then the parents will be happy also. Right? So not difficult. Patient, I mean, very spontaneous one. They are not in pain. They're nothing. They start to smile. They start to having joke with play around. Compared to adults sometimes attention seeking. No pain also they pretend pain. Yeah, but children are very easy. Yeah. Yeah. So memory making also can help in helping pediatrics patient memory making. So tell them, oh yeah, yes, they are going to go, but this is a way to show that the child is here before. Take photography, do some artworks, so do the hand printing. So those kind of activity together will actually help the patient.
And the parents, I suppose.
Yeah, and the parents, yeah.
Okay. Well, I have a question for you. Basically, it's of a referral to this domiciliary team. Okay. So what if I can afford to provide you with all your information and bring my patient back to my hospital? Do I still have to go through the referral to the government team before they refer to you? Because some of my patients are living from the Sepang area. Some of them are Semenyih kind of thing. It's far reached for me to go and visit. Usually, unfortunately, the referral is rather late. So most people is going to be a terminal discharge. And they just need somebody to kind of overlook what's happening. So can I do the referral directly in in the interest of time, really, because they don't
Definitely.
have much time.
Yeah, so we can't actually refer the program through the normal official pathway to domiciliary because the policy set as such, because there are some concern about I mean some financial things like not so I think what we can do, what suggestion that I can do is you can actually see which clinic is the nearby clinics.
Oh, okay.
Then call up their specialists
Right.
and refer case by case basis.
Okay. Yeah.
Yeah. So that is one way that we go around. But if in the beginning, the KKM don't allow private to refer straight away to domiciliary because of that is a home service thing. So about costing, about financial thing lah. There's some concern previously. So they must go through Klinik Kesihatan and go through hospital. But we
So how
work
long
around.
does that process take? Let's say that,
Normally, if you call case by case basis, right? Just call the specialist in the Klinik Kesihatan and say, hey, I need to refer your patient. Can I, this patient is terminal care lah. Probably
Yeah.
can you see in 1 or 2 days time? Then normally the case by case. So that's why the specialist sometimes will comply to it.
Right, because I can provide all the injectables really. It's just that, to oversee what's happening because
Yes.
symptoms might change night, isn't it? And try not to come back to the hospital.
We are better now. Last time when people call up and say, can you take over my patient, palliative patient? I don't want a patient going to die. What you want me to do? So, but over past 2 or 3 years, more awareness is there. They are daring to take the case. But one thing normally we'll say, don't worry, I'm going to support you. If you have anything, call me back.
Yes, call me back.
Yeah,
yes, I'm happy to receive a call.
Correct.
And we are well. I'm quite happy to prescribe the pre-filled syringes so that relatives can come and collect it from us. It's just that it needs to be given to the patient properly.
Yes.
We do the carers training in the hospital. Don't know how the home circumstances are. I do home visits as well, but it's only 10-kilometer radius. I can't afford further than that.
So I try to push domiciliary in Klinik Kesihatan because Klinik Kesihatan is everywhere, even in Sabah, Sarawak. Our hospice is focused in town area. So the one in rural area actually can benefit from it. But we need some time to develop the program because it is relatively very new.
Oh yes,
right?
Definitely.
Yeah.
Do you have any more questions from the audience? No, so far?
Yeah, maybe it is not so clinical, right? It is a bit abstract. Sometimes we talk about palliative care, talk about meanings of life, not so much of like medical. Yeah.
It is very important. KK work in.
Yeah, in Klinik Kesihatan Salak, Sepang.
And which area do you cover, Dr. Teoh?
The whole Sepang.
The whole Sepang. Okay.
The whole Sepang. Actually, in KL now, in Klang Valley now, we already try to map the service. Actually, every district, they already have their domiciliary team. For example, like Petaling, big one, they have 3 teams running around. But when we talk about palliative care itself, probably hospice will be a better person to run the service because they already, well equipped. They have knowledgeable on that. So, but we are following to try to do some cancerous one to complement each other.
Good. Yes, very important indeed. Do you have any more questions? With 43 participants, I can see. If there is no more, I think I'll hand it over back to Dr. Kelvin.
Yeah, if there's no more questions from the floor, we end our session here. Thanks again to Dr. Teoh for the wonderful and informative talk, and Dr. Ummi for chairing the session, and everyone for participating. We will see you again next week. Bye.
Okay. Bye-bye now.